In April, a study published in Science reported that an AI model reached the correct or near-correct diagnosis in 67% of emergency department triage cases. Human clinicians, working under the same constraints, managed between 50 and 55%. That result is real, it is peer-reviewed, and almost every headline written about it was wrong in the same way. Because the headline everybody ran was that AI beats doctors. What the study actually tested was a model working on a written case against a clinician working on the same written case under matched constraints. That is a real and meaningful test. It is not the job. And the gap between those two sentences is where this entire subject lives. So here is the plan. What was actually measured precisely? The second study, which is arguably more impressive and got less attention. The cancer results, which are the strongest findings in the field right now. Then the failure mode that worries me most, which is not the AI being wrong. And what would need to be true before any of this touches your care. First, what was measured? The model was assessed on real-world emergency department cases across 5 complementary experiments. It performed triage, recommended appropriate diagnostic tests, and handled case management tasks. On those tasks, it matched or exceeded well-trained physicians. Note what is not in that list. No physical examination. No patient in front of it. No decision made while 3 other patients were deteriorating. Then there is the second study, which I think is the more impressive one and got a fraction of the coverage. Published in Nature Medicine, it tested a system called AMIE in simulated consultations that included images. It outperformed primary care physicians across 29 of 32 evaluation categories. Not just diagnostic accuracy, also the breadth of the differential, meaning the list of things it considered and did not dismiss. And that second part is the genuinely interesting result. A differential diagnosis is the list of things it might be. Human clinicians narrow that list fast, because narrowing is how you function under time pressure. It is a feature, not a flaw. But narrowing early is also precisely how rare conditions get missed for years. A system that does not get tired and does not need to narrow is good at exactly the thing humans are structurally bad at. Then the cancer results, which are the strongest findings in this field at the moment. In April and May, 2 peer-reviewed studies reported systems identifying 18 distinct cancer types from a handful of tissue slides and detecting pancreatic cancer up to 3 years before conventional diagnosis. Pancreatic cancer is worth pausing on. It is usually found late, and being found late is most of why it kills. And there is a use for this that gets almost no coverage because it is not about replacing anybody. The comparison that dominates the discussion is AI against a good doctor. But an enormous number of people on Earth are not choosing between AI and a good doctor. They are choosing between AI and nothing. No specialist within 100 miles. A 6-month wait for a referral. A clinic with 1 overloaded generalist. Against that baseline, a system that reaches a near-correct diagnosis 2/3 of the time is not a threat to the profession. It is the only second opinion available. Though I want to be exact about that 67% because it is doing a lot of work. The measure was the exact or very close diagnosis. Very close is carrying weight there, and in medicine the distance between close and exact is sometimes the whole thing. The clinicians were working under matched constraints, which is fair, and also means they were denied things a real clinician has, like the ability to examine the patient or order a test and wait. And a triage decision is not a treatment decision. Being right about what department someone belongs in is a genuinely different task from being right about what to do next. Now the failure mode, and it is not the one people expect. The risk that concerns researchers most is not the model being wrong. Models are wrong at a measurable rate, and a measurable error rate is a manageable engineering problem. The risk is what the presence of a confident machine does to the human beside it. This has a name. Automation bias. It is the well-documented tendency of a trained professional to defer to a system's output, especially when tired, and especially when the system is usually right. And there is now research specifically examining automation bias in language model-assisted diagnostic reasoning among physicians trained to use AI. That is the important detail. The people studied were not skeptics who had it forced on them. They were the trained users, which produces an uncomfortable shape. The better the system gets, the more reasonable it becomes to defer to it. And the more people defer to it, the fewer independent checks exist on the cases where it fails. A system that is right 95% of the time may be more dangerous than one that is right 70%, because nobody double-checks the first one. And it is worth being clear about what peer review does and does not guarantee, because the phrase gets used as if it settles things. Peer review means qualified people checked the method and found it sound enough to publish. It does not mean the result has been reproduced. It does not mean it holds in a different hospital with different patients and different record keeping. It does not mean the effect survives contact with a system that was not built around the study. Publication is the beginning of the evidence, not the end of it. There is also a distinction being quietly collapsed in almost every headline about this. A tool that assists a clinician and a tool that replaces one are not the same product, they do not carry the same risk, and they are not regulated the same way. Every study here tested assistance. The model read a case and produced a view, and a human remained in the loop. Nobody has run the trial where the machine decides alone, and the reason nobody has run it is that no ethics board would approve it. Which means the most important experiment is the one we do not have. So what stands between these results and your actual care? More than most coverage implies. A study measures performance on curated cases with known outcomes. Deployment means messy notes, missing history, and a patient who describes symptoms in the wrong order. A study reports an average. A clinic needs to know the failure cases specifically. And a study is evaluated by researchers. A deployed device is regulated, audited, and has to say who is liable when it is wrong. And that last one is the genuinely unsolved problem. If a physician follows the model and the patient is harmed, who is responsible? If a physician overrules the model and the patient is harmed, and the model was right, what happens to that physician? Neither question has a settled answer. And the second one is how you get automation bias by policy rather than by psychology. So here is where I land, and for once on this channel it is mostly optimistic. These results are real, they are peer-reviewed, and diagnosis is a genuinely good fit for what these systems do well. Breadth without fatigue. Pattern recognition across more cases than any person could read in a career. Finding pancreatic cancer 3 years early is not a productivity gain. It is somebody's parent. But the thing that decides whether this helps is not the accuracy number. It is whether the humans stay awake. So where do you land? Should this be deployed fast because the accuracy gap is already large and every month of delay is measurable harm to people who would have been diagnosed earlier? Or slowly because the failure mode is human deference rather than machine error, and we have no liability framework and no answer for the physician who correctly overrules it? Tell me which, and tell me what evidence would move you. Everything here is sourced in the description, and none of it is medical advice.